Hey there! Did you know Kroger always gives you savings and rewards on top of our lower than low prices? And when you download the Kroger app, you'll enjoy over $500 in savings every week with digital coupons. And don't forget fuel points to help you save up to $1 per gallon at the pump. Want to save even more? With a Boost membership, you'll get double fuel points and free delivery. So shop and save big at Kroger today. Kroger, fresh for everyone. Savings may vary by state. Restrictions apply. See site for details. Hey there! Did you know Kroger always gives you savings and rewards on top of our lower than low prices? And when you download the Kroger app, you'll enjoy over $500 in savings every week with digital coupons. And don't forget fuel points to help you save up to $1 per gallon at the pump. Want to save even more? With a Boost membership, you'll get double fuel points and free delivery. So shop and save big at Kroger today. Kroger, fresh for everyone. Savings may vary by state. Restrictions apply. See site for details.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I am your host of Yoga Birth Babies. And today we're going to talk about what else? My favorite topic, the pelvic floor. And you're probably thinking, oh my gosh, Deb, how many more times are we going to talk about the pelvic floor? But we're going to talk specifically about tears versus episiotomies, what episiotomies are, and how one heals from both situations. So to have this conversation, we have Dr. Heather Jeffcoat. Let me tell you a little bit about her. Dr. Jeffcoat is a graduate of the Doctor of Physical Therapy program through Duke University of Medicine. She founded Fusion Wellness and Femina Physical Therapy in 2009. She's also the president of the Academy of Pelvic Health Physical Therapy and on the advisory board of the International Pelvic Pain Society. Dr. Jeffcoat is also the author of Sex Without Pain, a self-treatment guide to the sex life you deserve. It was such a great conversation. We are very like-minded in how one supports their pelvic floor and pelvic health. And she talked a lot about the different types of tears one may get from having a vaginal birth. She talked about healing. She talked about episiotomies and healing from that. And we talked about ways that during pregnancy, you could start to think about how to minimize the chance of tearing during birth. A lot of it, hint, hint, has to do with birthing positions. We get into that. So I think you're very much going to enjoy this conversation and leave feeling empowered, knowing that you have choices in how you can prepare and how you can birth, and recognizing that our bodies are pretty amazing. So I'm quite confident you're going to love this conversation. Before we get to that, I just want to give you a little bit of an announcement. So things are finally opening back up. Hooray. So we're slowly adding some in-person classes back into the studio. That said, we are still 100% committed to staying with our online classes as well. So for those either coming into the studio or taking classes online, for our podcast listeners, we've got a special code YBB10, which will give you 10% off of our yoga package. Not the single classes, but our different packages. So the more yoga, I think the happier one can be. So check that out. And I look forward to seeing you either online for our yoga classes online or in person, or maybe you're switching back and forth between both. We have some people that take online some days and come into the studios the other days. So yay, I look forward to seeing you in class. What else is going on? We've got a free downloadable. So if you can't make it to class, maybe, a whole 90-minute or 60-minute class is just not fitting in your life, we've got a free downloadable. So you can go to prenatalyogacenter.com and download 5 simple solutions to the most common pregnancy pains. And in that downloadable, you're going to get a bunch of asanas that can attend to your 5 most common aches and pains of pregnancy. So if you only have 10 minutes one day, I got you covered. I got some poses for you, and I hope that you'll feel better afterwards. And then last thing I want to share, our teacher training. So we are going to continue to do some online and some in person. It's kind of amazing to think how quickly we pivoted to our online teacher trainings and really how amazing they've been. And what I absolutely love is not only have we been able to continue our trainings, but we're reaching and working with people from so many different countries and parts of the US that we may have not been able to work with before. And what's just so beautiful about that means that these people that may not have been able to travel to New York can bring this important work to their communities. They can be there to support people in a prenatal yoga class or postpartum class, build the resources of their community. I think the yoga work is so deep and so much more than just an asana practice. So it's just really exciting. So if you're interested in our teacher training program, go also to our website, prenatalyogacenter.com, and check that out. And of course, always shoot me an email if you have any questions. All right, that is enough from me. We're going to take a super quick break, and when we come back, please enjoy our conversation about tears, episiotomies, and the pelvic floor with Dr. Jeffcoat.
Hey there! Did you know Kroger always gives you savings and rewards on top of our lower than low prices? And when you download the Kroger app, you'll enjoy over $500 in savings every week with digital coupons. And don't forget fuel points to help you save up to $1 per gallon at the pump. Want to save even more? With a Boost membership, you'll get double fuel points and free delivery. So shop and save big at Kroger today. Kroger, fresh for everyone. Savings may vary by state. Restrictions apply. See site for details.
Hi, Dr. Jeffcoat. How are you?
I'm so great. Thank you, Deborah, for having me on your show.
I'm really excited to speak with you. I am a pelvic floor junkie. I've learned as much as I could about it. I had my own pelvic floor physical therapy after my first child. And anytime I can have a conversation with someone about pelvic health and healing after birth just thrills me. So thank you so much for being here.
No problem. I appreciate the invite. I'm excited.
So we're going to talk about tears and episiotomies and the healing and just trying to get our head around all that. I know it is often a concern for many of my students. What if I need an episiotomy? What is the healing going to be like? What if I tear? So let's dive in. But before we get to that, I would just love to know a little bit about you and how you got started on focusing on pelvic health.
Yeah. So, I honestly, like when I went to physical therapy school, I did not even know this was an option, right? Like I, as a woman, was so uninformed that this was something I could go into. But through my graduate education at Duke University, they had a lot of electives, a lot of just sort of interjecting pelvic health and women's health topics into like our orthopedic lectures, for example. And so it really started to develop this interest for me, but I still, even at that point, wasn't 100% sure that if it was for me or not. I didn't go to school for this. So I started off in orthopedic and sports medicine and did that basically exclusively for a little over a year. But I didn't really like the setting, the practice setting of that. It's just, it's high volume. I just felt like I couldn't really connect with my patients. I just felt like I wasn't helping them. And here I just went to like a 3-year doctorate program, and I'm coming out and I'm not even able to use all these skills that I have. So at that point, one of my friends was working at a place that did pelvic health. And I'm like, okay, well, this is not really why I went to PT school, but I sure do love this like one patient every 45-minute thing. Maybe I'll look into it. And so I took my first class. I really loved it. Like, you take your first pelvic floor class, and I don't know, it's like hard not to fall in love. And I mean, it's just, I'm like, how did I not know about this? It felt so empowering, even like as a woman, to leave with all this like knowledge that not only helped me, but now it feels like this missing link with a lot of patients' care, especially postpartum. So I just, took more and more classes and developed, just a love for it. And that's sort of like the start to my journey. And, I've been doing it, I would say exclusively ever since. So that's like almost 20 years. But in pelvic health, we do a lot of orthopedic stuff, like hip and back issues can typically drive pelvic floor issues. So I'm still always using my ortho stuff. I do orthopedic continuing education as well as pelvic health continuing education, because we really have to approach pelvic health conditions as a total body condition for patients to get an optimal outcome.
Yes, I'm going to try not to digress too much, but that is something the more and more I study pelvic health is really the kinetic chain everywhere, that your SI joint hurts. It could be your pelvic floor. You could have weak adductors or dropped arches and it could be your pelvic floor. So it's amazing how it all works together.
Oh, absolutely. And I know that, this talk, I think, is probably going to be more pelvic floor centric, but I think it's always worth educating people at the beginning to just know that there's so much more beyond your pelvic floor that could be contributing to your pelvic floor issues. And this is only a piece of it that we'll be talking about.
Yes. All right. So, but, oh my gosh, my brain bubbling with thoughts. Okay. But I'm going to try to stick to topic. So, all right. Topic, tears and episiotomies. So one of the things I had heard very early, so I've been in the perinatal world for a little over 20 years. And when I started my doula career, and this was a while ago, I heard some care providers say, it's so much easier to repair a straight cut as opposed to a jagged tear. And I'm glad that I feel like for the most part that thinking has stopped. But what are your thoughts on that?
Yeah, so it's, I guess I never really timed this person took 4 weeks, this person took 6 weeks, but I do know that it was older thinking, exactly what you said. And that several years ago that changed based on actual evidence. So that's really what I more point to is what is the research showing, what are they recommending? And I do know that there was a switch a few years ago that episiotomies were shown to possibly increase the risk of third and fourth degree tears, which we also call oasis tears or obstetric anal sphincter injuries. And they can increase the risk of wound infections, and that doesn't seem to be protective of long-term complications either in the pelvic floor, like urinary incontinence or pain in the perineal region.
Yeah, I think a lot of people thought, I'm better off having that straight cut where maybe I'm avoiding more issues. But you're right. The research is saying actually you could have more. Yeah.
And so I just, go with the evidence, that's really what we can do.
What I realized I also didn't say as I jumped into tears versus episiotomies, for those that might be new to this podcast or just the world of birth, we didn't really define tears and episiotomies. Do you mind doing that?
Great. Yeah. So thank you so much for asking that. So, we typically will define a tear as a first, second, third, or fourth degree tear. A first degree tear is a very small tear where it's basically just the skin of the perineum. The muscles are completely intact. So that's a first degree tear. A second degree tear, your pelvic floor muscles are torn, but just think of it, it's just a little bit of a tear. There's no involvement that goes down towards the anal sphincter. Now, when we start to get third and fourth degree tears, that's when we start to have increased incidence of bowel or fecal incontinence because we have tears through the anal sphincter, and it's to different degrees. So with a third degree tear, not only are your pelvic floor muscles torn, but they go all the way to the level of the anus. And then those can also be subgrouped depending on how much of the external anal sphincter is torn and whether it's your internal or your external anal sphincter. So that's more of a medical thing, but basically it's to the level of the anus. And then a fourth degree tear is that the pelvic floor muscles are torn through the anus. And this is where people will, if it's not caught at the beginning, they'll complain that they're pooping out of their vagina, which should not happen because those are separate canals. Mm. So it involves the entire anal sphincter complex in a fourth degree tear, as well as through the rectum. And those third and fourth degree tears are those oasis tears, obstetric anal sphincter injuries.
Oh, and all I could think of is they must, not only is that probably very uncomfortable, they probably get a lot of urinary tract infections if they're having fecal matter going there.
Oh, I mean, absolutely. That could be a big problem. But I mean, usually they're cut. I've had, like, in almost 20 years, I've had maybe 2 patients where it wasn't, that had that severe of a tear and it wasn't cut at the time of delivery. And then they had to go back in for surgery.
So I'm thinking, if I was a listener and I'm hearing about the 1st through 4th degree, I'm like, oh, 1st degree, okay, and 2nd, okay, and then you're like, oh my God, 3rd degree. So how often or what percentage are people, I know, and I'm just throwing this at you, so you may not know, but those that have a vaginal birth, where does this lie? Like, what percentage probably gets a 1st compared to a 3rd and 4th?
Oh, so the 3rd and 4th degrees are pretty rare, and I wish I knew the exact percentage, but it's more in like the single digits. Like, it's not like 25% of women will have a oasis tear. So it's a pretty small incidence, but I do know that they are more likely to occur with your first vaginal birth. If you have like a large baby, over like 9 pounds, I think is the cutoff for that. And if you have like a long 2nd stage labor, so that's our pushing, the phase where we're pushing our baby out. And then if the baby's shoulder gets stuck behind the pubic bone, and with an instrumental vaginal birth, which would be like a vacuum assisted or forceps delivery, those do significantly increase the risk.
So I'll make sure that I put in our show notes about different pushing positions that can also help or not so much help. So like pushing on your back with your legs way back to your armpits, that is not, especially if you think that you have a 9+ pound baby, then the conversation needs to be, well, with that information, what other positions can I push in that's more protective of the perineum? So I'll make sure I put that in the show notes.
Oh, yes. I mean, and that's part of what we do with our birth prep program in my offices. So in whether or not we know they're having a 9-pound baby or not, because sometimes the patients will come in and they're like, oh my gosh, I'm 36 weeks and my baby's already measuring 9 pounds. Like, there's definitely some error in that. Yeah. So regardless of, the size of the baby, and if, we encourage them to have talks with whoever is delivering their baby, especially if it's like hospital based, because like the home births and the midwives and the birthing centers are always more flexible with that positioning. But like, according to research, there is support to show that there are fewer amount of those perineal tears, and delivering in like side lying or on your hands and knees can be protective of that, of the perineal area. But of course, like if you've had an epidural, you're going to be more limited. Like,
we can definitely do side lying if you,
exactly.
Yeah, I love, you're speaking my language about, let's look at other positions that are not flat on the back. Side lying, I love, because you can have an epidural, you can get some internal rotation of the top leg. It just creates a lot more space for babies. So I love that we're giving actionable tips, so that if someone's like, oh my God, tears, now we can say, yeah, but there are ways that we may eliminate a little bit of the risk. So let's also then switch to an episiotomy. What is that, and what happens to the pelvic floor?
Yeah. So an episiotomy, just in case maybe people don't know how to define that, it's the surgical incision that your OB will do at the time of delivery to basically create more space of the vaginal opening. And that's really the only time that technique is ever done. And if they are done, they're usually done off center, because if they're done in the center and it's a large tear, then that can continue to, possibly create those 3rd and 4th degree tears. And by definition, an episiotomy is a grade 2 tear. So, if you have one, then you have at least a grade 2 tear.
So great. Now we understand. Now we have kind of our language under control, and now people understand the different types of tears. So if you have someone coming in and they're working with you, I'm guessing that someone's not likely coming in for like a 1st degree tear. So when are you probably seeing people, like 2nd, 3rd, 4th?
Yeah. So ideally, if they've come in from our birth prep program, then they're coming in, even if they have a first degree tear, because just being pregnant increases your risk of pelvic floor dysfunction. But if they're coming in and entering postpartum for the first time, they're usually like a grade 3 or 4. They're not necessarily coming in for a grade 2 tear early postpartum. Like I'm talking first couple months. They're coming in if they've had like a grade 2 or less, usually more if they're having like incontinence or pain, like pain with sitting, painful intercourse, things of that nature. So we see them at all levels. It just is kind of where they enter in, like how far postpartum they are.
So what would the healing most likely, and I'm going to say most likely because we know nothing's 100%, but with the first and second degree tear, what is the healing process most likely for somebody?
Like how long will it take?
Like what should they expect? Just a little tenderness or the muscle regenerates like in a few weeks?
Yeah.
Or?
Well, okay. So yeah, just regarding the wound itself, it should be less than 6 weeks, like 4 to 6 weeks, for grade 1 or 2. They might have some pain with sitting. It might stretch the perineum a little bit when they're sitting. They might feel the stitches. You do always have to watch for infection risk, whether you have a grade 1 or a grade 4. If there's a cut there, there's always going to be a risk of infection. So it's sort of more the timeline, I guess. Grade 3 or 4, the tissue itself may heal in that same time frame, but they will still have long-standing problems after. So we have to be careful how we use the term healing, I guess. It's more in like, does what's called like the granulation or the healing tissue, so that, okay, you don't have an open wound anymore, but your muscles are far from healed 4 to 6 weeks or even, 10, 12 weeks postpartum. That has a lot more to go.
So when you have someone, let's start again with just like the first and second degree tear, and the wound itself has healed, there's no infection. Does that person, are they pretty much likely to have normal pelvic floor function? Do they need to start to look at regenerating muscle tone, or are they pretty much good to go compared to your third or fourth degree, which we'll get to in a moment?
Yeah. So, no, like every postpartum woman should see a like pelvic floor rehabilitation specialist, pelvic PT, to evaluate their muscles, because being pregnant increases your risk of pelvic floor dysfunction. So even if they had a C-section and they didn't push at all, it was an elective C-section, they are still at higher risk for pelvic floor dysfunction than somebody that was never pregnant.
That's actually something I find fascinating, because like I understand like the fascia. I've had so many people say, "Oh, I've had a C-section, my vagina's fine." I'm like, not necessarily.
Nope, it's not. And I mean, and there's data on, like, for example, because I do so much with sexual health also. So on like the percentage of women that have painful sex on their first attempt after delivery, and how many, which is almost 9 out of 10 women. And the ones that were at a higher risk of having painful sex were those that had an elective C-section, a emergency C-section, or like the instrument assisted vaginal delivery. The ones that had the least reported incidence of painful sex were those that had a natural, uncomplicated vaginal delivery. And, the data that's even looking out, like it's 6, 12, and 18 months. 18 months later, 25% of women, or like 23%, somewhere around there, are still having painful sex. So,
that's high.
1 in 4, 18 months later. So you have to, I guess to make the point that people do say exactly what you said. Oh, my vagina is all good. Like I had a C-section. And for some, that might even be factoring into their decision to have a C-section, because they don't want any changes in the vagina. But it does happen when you're pregnant. The increased load that you have to carry from the baby, that you're carrying, postural changes in those last few weeks when those relaxin levels start to peak again and you get more joint laxity. Your pelvic floor is working overtime, almost working nonstop. So you can really tend to develop more of an overactive or a non-relaxing pelvic floor because of these constant demands that are on it. And those don't just go away when they've been there for weeks, or longer, depending on any pre-existing conditions you might have had, or any like concurrent conditions that you may have developed, like back pain and hip pain, because as we talked about at the very beginning, how those can affect pelvic floor muscle function and your ability for your pelvic floor muscles to relax or not relax. It's all dependent on multiple factors. So yes, I think like even if they just had a grade 1, they should, really seek an expert in their community to see what, even though I didn't have much tearing, what else could I benefit from to help get me back safely to exercise or to work or whatever activities they need to get back to.
Yes, yes, yes. I'm all about reminding the students that if it's within their means and they have it in their community, pelvic floor PT can just tell so much about what's happening and give support and things that they, like you said, might not even know, like, oh, my back is hurting or my upper back, like any part could be related back to the pelvic floor. So let's talk about healing and muscle regeneration and what you would do with somebody that has a grade 3 or 4 tear.
Yeah. And I'm really hoping that they come in sooner rather than later. Even like while the wound is still healing, because we have modalities like we have red and infrared light, which helps with wound healing. So it actually can speed up the healing time. We have blue light, which helps with infection. So it's like the same type of blue light they would use to, in a hospital to disinfect, in the operating room, for example. So, we have ways that we can help minimize infection and improve healing rate. And those are, if they have a 3rd or 4th degree tear, we're using that on them. But if they're coming really early, I'll use it on a 1st or 2nd degree tear too. Mm-hmm. No internal work or assessment until they are cleared by their midwife or OB for an internal assessment, because we don't want to disrupt any healing that has, yet to occur. And, we have to kind of assess them and see what are their dysfunctions. Are they limited because of, maybe they're limited in strength because of, their muscles being really underactive. So we might need to uptrain or work on strengthening and like pelvic floor muscle facilitation techniques to help engage their pelvic floor. Or maybe their muscles are really overactive from this trauma and the body has, like when you have whiplash, right? Like your muscles go into spasm. So maybe there's more of like an overactivity that we actually need to do muscle down training or relaxation techniques prior to eventually moving towards strength, because they will need strength. But your muscles essentially can be weak if they're underactive or overactive or somewhere in between. Like there's a whole lot of reasons your muscles may be weak, but starting with strengthening isn't necessarily the place that you start just because your muscles are weak. Because if your muscles are weak, short, and tight, you're just going to make them shorter and tighter, and they're going to continue to stay weak. And then that can have downstream effects on other places of your body, like lead to other dysfunctions.
I want to just highlight for everyone listening, listen to that, rewind it, and listen to that again, because many care providers, and this is not a dig on them, will after your 6-week checkup just say, great, just do your Kegels. And let's just again say short and tight. If we keep contracting, we'll get shorter and tighter. So if you're having incontinence, it can get worse. Pelvic pain can get worse if we keep going short and tight. Just want to like stars and highlight that.
Yes. And I don't know if your show notes can include like diagrams, but if anyone, when you get home or listen to this at home, if you Google length, tension, relationship, skeletal muscle. Like I know it's a mouthful, but if you do that, you're going to get a bunch of images, and the images are going to look like a bell-shaped curve, but it's going to immediately give you that visual of, oh, my, muscles, on this up and down axis, this is showing the force that my muscles can produce. And this left to right axis is showing the length of my muscle. So when you're short and tight, you can see very much that you can't produce a lot of force. And when you're long and overstretched, like your abs are when you're delivering, your abs for sure get overstretched. They're also weak. And you can feel that when you get up after you deliver, that you don't have good overlap of the muscles. You don't even have that good like internal feedback that the baby was providing. So it's just a nice visual to see like, oh, wow, okay, I shouldn't be doing Kegel feel just because I might be peeing my pants. Like I can see that now. So some people are very visual.
Yeah. I'll try to find something I can do for that. Oh, I love, like, you and I are very in that same mindset here. Okay. So we're going to take a quick break. And when we come back, let's talk a little bit more about episiotomies. We'll be right back.
Hey there. Did you know Kroger always gives you savings and rewards on top of our lower than low prices? And when you download the Kroger app, you'll enjoy over $500 in savings every week with digital coupons. And don't forget fuel points to help you save up to $1 per gallon at the pump. Want to save even more? With a Boost membership, you'll get double fuel points and free delivery. So shop and save big at Kroger today. Kroger, fresh for everyone. Savings may vary by state. Restrictions apply. See site for details. Hey there. Did you know Kroger always gives you savings and rewards on top of our lower than low prices? And when you download the Kroger app, you'll enjoy over $500 in savings every week with digital coupons. And don't forget fuel points to help you save up to $1 per gallon at the pump. Want to save even more? With a Boost membership, you'll get double fuel points and free delivery. So shop and save big at Kroger today. Kroger, fresh for everyone. Savings may vary by state. Restrictions apply. See site for details.
All right. So let's talk about episiotomies. So it's, as you said, it's immediately a second degree tear. And how are you finding the healing process compared to that of an uncut tear? And how do you go about working with someone with that?
Well, from my perspective as a pelvic floor physical therapist, I'm just doing everything I can to help speed their healing process. So I'm using my red and infrared light for the wound healing. I'm using the blue light to help minimize the chance of infection. And once the tissue is healed and I've been cleared for internal assessment, I'll just assess how much scar tissue is there because, we all form scars differently, right? So some people form those really thick keloid type scars. Other people, it's like a white line. It's like you had a baby. Like there's just, I don't even see anything hardly. So, so feeling for the restrictions, in the scar tissue itself, looking at their muscle contraction ability, their muscle relaxation ability, seeing if there's any asymmetries on each side, is there scar tissue on that side? Could that be contributing to the fact that they can't get a good contraction? Are their muscles underactive, overactive? So it's whether it's a natural or a natural tear or an episiotomy, I am doing the same thing from a physical therapy perspective.
All right. I wasn't sure. I was just wondering how, that was very interesting. So let's talk a little bit about scar tissue. I know when someone has a cesarean, they often do like a scar tissue mobilization massage. What are your thoughts about that for the pelvic floor?
Yeah, same. Because if they had a vaginal delivery with any amount of tearing, that's something that should be assessed for because that's going to limit their functional mobility, right? If it's really bad, it could even limit them possibly being able to use a tampon in the future once their periods come back. Or it might just, not be as severe, but can make them have pain or discomfort during intercourse. But sometimes those, like that scar tissue, it can feel like shards of glass. So when I say pain, like it can range. It could feel like, it feels like a little sore, but sometimes it feels like shards of glass or like their skin is ripping. And, there's different levels of sensitivity that can have, just like a cesarean incision can, like, mamas that can't like wear pants over the incision because it's so sensitive, so we can do desensitizing techniques, more like manual manipulation techniques that can actually help to break down the scar tissue and remodel it, along with the adjacent muscle work that we'll do to try to get things in balance.
So is this something that if someone does have scar tissue from any sort of healing, are you usually seeing it more with higher degree tears, or do you see this with some, I call it skid marks, like the first degree?
I definitely with those oasis tears, those grade 3 and 4s. Sometimes with grade 2, if someone had a grade 1, not usually so restricted, with that, because, and the tear doesn't even go into the muscle, right? It's just skin. So that's usually pretty minor, if anything at all. But yeah, 2, 3, and 4.
And
I
so
definitely do.
Is it something that they have to, if someone has that, are they needing to go see a pelvic floor PT for that? Or can they do it on their own? Or is it something they can be taught to do on their own?
Well, I empower my patients with a home program. So all of my patients know how to do it on themselves. Whether it's any muscle related issues that we find, like overactive pelvic floor muscles, they'll learn how to use medical dilators to work on the muscles themselves in various ways, basically applying general orthopedic or, manual therapy techniques to the pelvic floor, like trigger point releases, special types of stretching to the muscles internally using the medical dilators. For the scar tissue specifically, there are scar mobilization techniques that also, I'm using the same mobilization techniques as I'd use on someone with a C-section, as someone that maybe had like a laparoscopic procedure in their abdomen, as someone that had like a knee replacement. And if they're getting a lot of scar tissue, it's all the same techniques. You just have to adapt it to the unique anatomy that is the perineum and the pelvic floor area. And but you can definitely do that on your own. Whether or not, if I say, okay, like put your thumb in, you use a little bit of lubricant, thumb inside, finger outside, and kind of like just like roll, like you're rolling like a pill, between your fingers. Okay. Yeah, there's some stuff you can do on your own. And if it's really minor, then that's fine. But your problems might not be exclusively scar tissue. They could be muscle related as well. So, I do know, pelvic floor physical therapy, even though we are a growing profession, we're not in every city and every state across, in every country. So there would definitely be accessibility issues. People like me, we're out of network, so we end up being cash based, and that can be financially inaccessible to some people. But even if they even just come, 1 or 2 times, like we can teach them so much. And so we'll have some patients that come in for their initial visit, and then maybe they come in 1 or 2 weeks later, and then they just come in like once a month or every 6 weeks because they have dysfunction. They know it. They maybe have urinary incontinence. They can feel that they have like perineal pain with sitting, or they have pain with sex when they tried to resume penetrative intercourse with their partner. But they might have limited time and or finances and or all of the above. So we empower them with a home program, and we teach them as much as we can teach them in the hour we're with them, and they go and they work on it on their own. But there's a lot that you can do to help yourself, definitely.
I think that's so important because, like you said, it empowers somebody to take charge of their body and then feel like they can do something, that they're not a victim of the situation. It's horrible to come out of a birth and be like, oh, now my body is just a hot mess. And to know that they can work with someone. And then I worked with the pelvic floor PT after my first birth. Now we were talking about episiotomies and how they're old fashioned. So I had a home birth, and there was one point when I was pushing and my home birth midwife said, do you want me to cut an episiotomy? And in my thoughts, I'm like, oh my God, where are we in the situation that a home birth midwife is asking me? Cause I think I yelled, can't you just pull him out? So my pelvic, even though it was such a long birth, I didn't have anything more than that's how I got the idea of the skid mark. Like, it was very superficial. He was 8 pounds. I pushed for 5 hours, and I was so fortunate. I did not have big tearing. I was shocked.
Wow.
But that said, so I went to see a pelvic floor PT because when one pushes for 5 hours, it definitely affects everything. And it was great that she gave me stuff I could do at home on my own. And I think a lot of people like knowing that they can do stuff on their own. They don't have to just wait for their appointments. I found it empowering, and it really it made me more confident about the healing process. So I'm glad that you give people an at-home program.
Yeah, it's a big, basically staple in my practice. Myself, my therapist, like on someone's first visit, our goal is that they leave with something to do, because as much as they'll still improve if they come in and see us every week. It's going to take more time if they're not doing something on their own. Yeah.
So let's talk about, at what point is it so severe that would someone possibly, their tear or they're not healing well or whatever, the tear is so severe that they may need surgery, or it's not recommended they even have a second vaginal birth? What are your thoughts on that?
Oh, I know I've had that question before, and I'm always like, oh boy, like you're literally asking me if you should deliver vaginally again because of that, and like whether you should even get pregnant again, like because of like the trauma you're associated with that delivery. But once even a severe repair is a repair of a severe injury, like that 3rd or 4th degree tear, the research says that most women can safely deliver vaginally in a future pregnancy. So, if that's really their, that's what they want in their birth plan, then that is what the literature shows. The risk of getting that 3rd or 4th degree tear is a little bit higher than, previous, like then the overall risk of having one with your first pregnancy, but it's still like in the single digits. And again, maybe I can like find those numbers for you that you can post after, but it doesn't give you like a 20% risk, or it's really low. It's really low. So I don't think that even with a severe injury and as long as it was repaired properly, right? So that's kind of the big if. And that, I did see that, if you're considering a cesarean section, that it's like there's a certain number of cesarean sections that would happen, that would, before there would be another like obstetric anal sphincter injury, the oasis tear. Like it's like, basically they wouldn't recommend it because it's, if you want to have a vaginal delivery, have a vaginal delivery. So, it's not necessarily supported in the literature to prevent, oasis tears. I mean, as a C-section will prevent them, I guess, but if your goal is to have a vaginal delivery, it's not, contraindicated to do so.
So let's talk about, we kind of dipped into this a little bit ago, but if someone wants to minimize their chance of tearing, what suggestions do you have for pregnant folks to think about prior to giving birth and then incorporate in the birthing process?
Right. So we did talk about the birthing positions in the beginning. So other things that we do in our birth prep program is identify while they're pregnant if their pelvic floor muscles are already showing signs of overactivity. There are signs of pelvic floor overactivity, but it is muddled with the fact that you have like a baby's head probably pushing on your bladder, but like a, urinary urgency and frequency, urinary incontinence, painful sex. Like those are some signs and symptoms of an overactive pelvic floor. And so through a like internal muscle assessment, intravaginal assessment, we can also, look for and sense like whether or not those muscles are stretching like they should. Is there pain associated with the stretch? And we're stretching. I mean, we're very gentle. Like I wish I could tell you like how many pounds of pressure, but it's light pressure. And if they're having pain to very light pressure, their pelvic floor is, showing signs of overactivity. So, what we would want to teach them, if that's the case, are signs or, are exercises for pelvic floor muscle relaxation. So, starting with breathing, educating them on the connection between the diaphragm and the pelvic floor. And I don't know if like you've covered this on previous podcasts or not, but
I covered every single yoga class because diaphragm, pelvic floor. And I'm just so happy you're saying this. Like there's a smile. I'm like, yes, that is my language. There's that relationship. So keep going though. Keep going.
So repetition is a great form of learning too. So there you go. So when you inhale and your lungs fill with air, your diaphragm drops or descends. And synergistically with that, your pelvic floor should drop or descend. So using that visual of like inhaling, breathing down into your pelvic floor, feeling that pelvic floor relaxation. I'll have patients do this on their birthing ball a lot of times if they have one, so that they can feel that like drop and push. And it's not a strain. It's just happening passively through the inhale, but getting that connection of pelvic floor muscle relaxation through the inhale. I will teach them how to use those medical dilators, like I mentioned a little bit ago, to start working on their overactive pelvic floor, doing trigger point release, doing intravaginal stretching, doing like perineal massage, all with the medical dilator, and helping them optimize how they're doing that technique so that they can just get more passive length in their muscles to prepare for delivery. And then going over birthing positions. Yeah, I think those are the sort of the keystones. Breath work, positioning, and intravaginal work.
That's such great advice. I'm so glad that I've been obsessed, I think you can tell, with the pelvic floor, but we talk about every class, but the more and more we can hear that, because again, I don't ever think it's out of malice, but so many people say, oh, you're pregnant, just keep doing your Kegels, Kegel, and we can just keep getting tighter. And I also really appreciate that you said the passive inhale helps lengthen, because I've also heard people say, like, try to puff out through your perineum or add a little bit of pressure. And that makes me worried about that downward pressure that we don't necessarily want on the pelvic floor. So I'm glad you mentioned the passive part.
Yes. And that way, just knowing, because I guess there is always that. I mean, I talk to them about pushing too and avoiding purple pushing, as like I call it. I mean, I didn't coin that phrase, but, not holding the breath, not doing that Valsalva technique where you're holding your breath. And so just helping them sort of like breathe down into it. And if they're practiced with it for weeks leading up to, then it'll be easy to implement at the time. So it just becomes part of what they do a couple times a day. And it's one-on-one. Maybe I'll record it one day, but it's all like our one-on-one individualized.
It's so important
right now.
Oh, it sounds like you're doing such great work. Okay. We're going to take a break. When we come back, if you would like to offer one tip or final piece of advice for new and expectant parents, it can be anything about anything that you want to share. We'll take a super quick break. We'll be right back.
Hey there. Did you know Kroger always gives you savings and rewards on top of our lower than low prices? And when you download the Kroger app, you'll enjoy over $500 in savings every week with digital coupons. And don't forget fuel points to help you save up to $1 per gallon at the pump. Want to save even more? With a Boost membership, you'll get double fuel points and free delivery. So shop and save big at Kroger today. Kroger, fresh for everyone. Savings may vary by state. Restrictions apply. See site for details.
So what is one final tip or piece of advice you would like to share?
So I think that, my patients, they know their bodies and they know when there is something wrong. So I think from the beginning, you need to not be afraid to advocate for yourselves, and don't let your provider, don't let your mom, your sister, don't let your friends normalize what has happened to you. If you are showing any signs of pelvic floor dysfunction, then the research shows that those don't get better over time. Women that are peeing their pants 5 months postpartum are still peeing their pants 5 years postpartum, the same percentages. So you need to just be proactive on getting yourself back on track, and don't let anybody tell you that what is happening to you is just a normal part of pregnancy or delivery, because you can be helped.
Yes. And you don't want to have it affect your whole quality of life. So that is really, it does. Yeah. We don't want that. So that is really, really, really good advice, because I hear so many students say, oh, it's just going to heal. This is just part of it. Oh, this is just part of being a parent. I'm like, no. So that is great advice. Now, where can people find your work?
So, I am Los Angeles based, and my website is feminapt.com. And I'm also on Instagram and TikTok at the Lady Parts PT. And then you can follow my private practice. We're on Instagram at Femina PT. So I'm kind of like every place you could look. There I am.
And then I believe you also have a promo code for your book. Am I correct about that?
Yes. So I did write a book on, it's a self-treatment guide because again, I'm so proactive with people having things that they can do on their own at home. So it's called Sex Without Pain, a self-treatment guide to the sex life you deserve. And it's basically how to properly use medical dilators, which will give you like a faster route to helping with overactive pelvic floor muscles. And those techniques can overlap and help with scar tissue sensitivity as well, although I don't talk about that in my book. But painful sex, as I talked about during our show, it's a big problem postpartum. So it really allows a way for women to be empowered to help themselves get their sexual health back.
Yeah, so that can also, I was going to say that could also affect quality of life as we're talking about.
So, that's a whole other side discussion. Yeah. Sexual health discussion, but, it's a 20% off with code PYC20, and on sexwithoutpainbook.com. So that's for a PDF download. If you want a print book, you can get that on Amazon. So
I will make sure that code is also in the show notes. Ooh, I'm going to have some long show notes. I'm going to see if I can get the visuals that you said. I'm a very visual person too. So I'll send you what I find, or you can send me what you think I should post, either way. But this has been such a great conversation. I'm just so thankful for how open you were with offering all of your knowledge. So thank you so much for chatting with me today.
Deborah, this has been such a great talk. Thank you. I love talking with like-minded pelvic floor individuals. So this has been amazing. Thank you.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.